Hello friends, today we are going to discuss about the principles of topical dermatologic therapy in today's CPE program. So topical dermatologic treatments are grouped according to their therapeutic functions, namely cleansing agents, moisturizing agents, drying agents, anti-inflammatory agents, antimicrobial agents, Keratolytics, Astringents and Antipruritics. The efficacy of a topically applied drug depends on its potency and its penetration. Some factors that affect the penetration include concentration of a medication, thickness and integrity of the stratum corneum of the skin, frequency of application, occlusiveness of vehicle and compliance. So topical applications or vehicles are meant to enhance the beneficial effects of the medication. Either the vehicle or its active ingredients may cause local toxicity, sometimes may induce systemic toxicity also. In fact, many potent agents such as hydrocortisone and fluoroquinolone acetonide are quite poorly observed after topical application. Conversely, many well observed agents with weak potency have negligible therapeutic use. In contrast, to many orally administered drugs that are nearly completely absorbed within a few hours, topical medicines generally have a poor total absorption and a very slow rate of absorption. For example, less than 2% of topically applied corticosteroids such as corticosteroid is observed after a single application left on the skin for more than a day. So furthermore, peak rates of absorption are reached up to 12 to 24 hours after application. For certain topical treatments, successful therapy may also depend on the two factors. One is vehicle and another is dosing. The vehicle with which an agent is formulated and also the type of dosing used for that particular treatment. So vehicles are usually combination of several chemicals like emollients, humectants, emulsifying agents, solvents and preservatives. Now we see some ideal properties of the vehicle. The vehicles should provide the rapid delivery of the drug to stratum corneum and into lower layers of the skin. So they should be easy to apply and cosmetically acceptable. The vehicle must also provide a medium in which the drug remains stable. Generally, powders, aqueous and alcohol-based preparations are dry because the liquid evaporates and are used in acute inflammatory conditions. So oily preparations are moisturizing and are preferred for chronic inflammations. See the table, it shows it helps to select the formulations for specific body sites. For example, if you want to select the ointment, you can see the suitable body sites. For ointment, it's preferred only to palms and soles, smooth and non-hairy skin, thick and hyperkeratotic lesions. Now you see, suppose if you use the wrong formulation, what will happen? You can see the response to therapy may be delayed or inadequate. In some cases it may worsen also. As an example, the use of corticosteroid gel on fissured and eczema will cause increased pain and stinging due to alcohol-based gel. Treating moisturizing within an ointment may cause folliculitis secondary to its occlusive properties. Now we will see some type of vehicles. There are three types of vehicles: powders, liquids, combination vehicles. Powders, actually inert powders may be mixed with anti-ingredients. Best example is antifungals to deliver therapy. They are prescribed for lesions in moist or intertriginous areas. For liquid vehicles, there are different formulations available like baths and soaps, foams, solutions, lotions, gels. In case of combination vehicles, examples are creams and ointments. So combination vehicles usually contain oil and water, but may also contain propylene or polyethylene glycol. We will see in details. Baths and soaps are used when therapy must be applied to large areas such as with extensive contact dermatitis or atopic dermatitis. Foams or alcohol or emollient based neuralized preparations, they tend to be rapidly absorbed and may be favored in hair bearing areas of the body. Foam preparations spread readily and are easier to apply than other preparations, particularly for inflamed skin and for scalp dermatosis. They are also often more cosmetically acceptable, which can lead to higher compliance. So unlike other vehicles, foams depend on the vehicle delivery system for the physical delivery of the drug. Because of the complexities in delivering the vehicle delivery system, foam preparations tend to be more cost expensive than other vehicles. Solutions are most often powders that are dissolved in water or non-aqueous liquids such as ethyl alcohol, propylene glycol, polyethylene glycol. Solutions are convenient to apply, especially to scalp for disorders such as psoriasis or seborrhea, but tend to be dry. One common solution is aluminum acetate solution. Lotions consist of suspensions or solutions of medication in water or alcohol or other liquids. They are easily applied to hairy skin and dry, acute inflammatory and exudative lesions such as contact dermatitis, tinea pedis, tinea coes. Thus, patients must shake the container before each application to receive the desired therapeutic concentration. Lotions are especially useful in hairy areas in conditions where large areas to be treated. In addition, the lotions evaporate to provide a cooling and drying effect, making them useful for treating moist dermatosis and pruritus. So gels or oil in water emulsion with alcohol in base, they dry in a thin, greaseless, non-staining film. Gel formations combine the best therapeutic advantages of ointments with the best cosmetic advantages of creams. They are cosmetically attractive to many patients. So gels are transparent, colorless, semi-solid emulsions that liquefy and contact with the skin. They are easily absorbed and are an efficient method for delivering topical corticosteroids to hairy bearing areas. Gels are often more effective for controlled list topical agents. They are often used in acne, rosacea and psoriasis of the scalp. Now we see combination vehicles. First one is creams or semi-solid emulsions. They contain 20 to 50% of oil in water. They are used for moisturizing and cooling and when exudation is present. They vanish when rubbed into skin. They are cosmetically appealing and can be washed off with water. For the same topical corticosteroid, cream formations are usually stronger than lotions but less potent than ointments. We see ointments. Ointments are oily based with little water. So this type of vehicle is an excellent lubricant. It facilitates heat retention. It decreases transepidermal water loss. Also, it provides enhanced medication absorption. It is also semi-occlusive. So ointments are generally the most potent formulations due to their occlusive effect, but patient acceptance and adherence to treatment may be low because they are greasy, sticky, and generally unsuitable for application to large burn areas or to hairy areas. They are preferred for intensified lesions and lesions with thick crust or heat up scales, including psoriasis and lichen simplex chronics. So ointments are less irritating than creams for erosions or ulcers. They are usually best applied after bathing or dampening the skin with water. Now we see dressings. So dressings are used to protect lesions. Also they facilitate healing and they increase drug absorption and protect the patient's protein. There are two types, one is non-occlusive and one is occlusive dressings. Now we'll see non-occlusive dressings. So these are most common non-occlusive dressings of gauze dressings. They maximally allow air to reach the wound, which is at times preferred in healing. and allow the lesion to dry. So they are non-occlusive dressings wetted with solution, usually with saline, that are used to help cleanse and debride thickened and crusted lesions. The dressings are applied wet and removed after solutions is evaporated, with materials from skin adhering to the dried dressing. Now we see occlusive dressings. So these dressings increase the absorption and effectiveness of topical therapy. The most common are transparent such as polyethylene or flexible transparent semi-permeable dressings. Examples: hydrocolloid dressings draw out fluid from the skin and form a gel, can be applied with a gauze cover in patients with cutaneous ulceration. Zinc oxide gelatin aqueous boot is an effective occlusive dressing for patients with stasis dermatitis and ulcers. Third one is plastic tape impregnated with fluoroadrenomide like corticosteroid, can be used for isolated or recalcitrant lesions. Now let's discuss about topical therapeutic agents. These are some therapeutic categories, major therapeutic categories we already seen, like cleansing agents, moisturizing agents, drying agents, anti-inflammatory, antimicrobial, keratolytic agents, astringents, and antipruritics. We will see one by one in detail. So what are cleansing agents? So principal cleansing agents are soaps, detergents, and solvents. So soap is the most popular cleanser, but synthetic detergents are also used. So baby shampoos are usually well tolerated around the eyes for cleansing wounds and rashes. They are useful for removing pus and scales in psoriasis, eczema, and other forms of dermatitis. However, actually irritated, weeping, or using lesions are most comfortably cleansed with water or acetylcholine saline. So water is the principal solvent for cleansing, and also organic solvents also used. Best examples are acetone, petroleum products, and propylene glycol are very dry, can be irritating and cause irritant, less commonly allergic or dermatitis. So removal of ardent tar and dried paint from the skin may require a petroleum based ointment or commercial waterless cleanser. Let's discuss about moisturizing agents. So these moisturizers restore water and oils to the skin and help to maintain skin hydration. They typically contain glycerin, mineral oil, or petroleum, and are available as lotions, creams, ointments, and bath oils. So stronger moisturizers contain urea 2%, lactic acid 5%, and glycolic acid 10%. So I used as keratolytics. They are most effective when applied to already moisturized skin. Cold creams are OTC moisturizing emulsions or fats. So excessive moisture in, now we see drying agents. Excessive moisture in intertibial areas like between toes, in the interglottal cleft or axilla, groin, and inflammatory areas can cause irritation and maceration. To avoid, powders are used. So powders are dry, macerated skin and reduce friction by absorbing moisture. However, some powders tend to clump and can be irritating if they become moist. Although talc is more effective, talc may cause granuloma if inhaled, so and is no longer used in baby powders. So cornstarch may promote fungal growth. Super absorbent powders are occasionally required to dry very moist areas. So aluminum chloride solutions are another type of drying agents useful in hyperhidrosis. Now we see anti-inflammatory agents. These agents are either corticosteroids or non-corticosteroids. So corticosteroids are the mainstay of the treatment for most non-infectious inflammatory dermatosis. There are some general recommendations. Actually, corticosteroids are classified according to 7 types. So super high potency corticosteroids are generally used for severe dermatosis. They are especially useful over the palm and soles which tend to resist topical corticosteroid penetration due to thick stratum cornea. So medium to high potency preparations are appropriate for mild to moderate non-facial or non-intravenous dermatosis. Low to medium strength preparations should be considered when large areas are treated. Eyelid and genital dermatosis should be managed with low potency topical corticosteroids for limited time periods. So topical corticosteroids are safer than systemic glucocorticoids. Small agents can cause local skin stray and acneiform eruptions when used more than a month. So corticosteroids also promote fungal growth. Contact dermatitis through corticosteroid itself may also occur. Perioral dermatitis occurs with mild, mid-potency or high-potency formulations used on the face. It is uncommon with mild formulations. High-potency formulations may cause adrenal suppression when used in children. Over-extensive skin surfaces under aqueous stressors or for long periods. Related contraindications include conditions in which infection plays an underlying role and acneiform disorder. You see the table, you can choose amount of the package based on the site of the body. For example, if you want to use for face and neck, for 1 week you can choose 15 grams. The same time for 4 weeks you choose 60 gram packet. For children, use 1/3 or of these amounts. So non-corticosteroid anti-inflammatory agents include tar preparations. Mainly, the tar comes in the form of good coal tar and is indicated for psoriasis especially. So adverse effects include irritation, folliculitis, staining of clothes and furniture, and photosensitization. So contraindications in infected skin. Several herbal products are also commonly used in commercial products, but their effectiveness has not been well established. Among the most popular are chamomile and calendula. So for atopic dermatitis, calcineurin inhibitors like formiclomus and tacrolimus and topical phosphodiesterase 4 inhibitor isoborol may be used. You see about antimicrobial agents. Maybe there may be like antibiotics, antifungals, insecticides, and non-specific antiseptic agents. Now we'll see first antibiotics. There are some few indications. Topical clindamycin and erythromycin are used as primary adjunctive treatment for acne vulgaris. Topical metronidazole or sulfacetamide or clindamycin or erythromycin are used for rosacea. Erythromycin has excellent gram-positive effect, gram-positive coverage, and can be used to treat impetigo. Rectamogulin and ozenoxin or other topical antibodies are used for impetigo. So what you see, antibiotics such as dactrazin and polymyxin have replaced by topical petrolatum for post-operative product of the skin biopsy site. So topical petrolatum is effective as effective as these topical antibiotics and does not cause contact dermatitis. Also, the use of topical antibiotics and washing with antiseptic soaps in healing wounds may actually lower healing. Now we see antifungal treatment principles. In general, antifungal infections are treated topically, except for those involving the nails or those deep in hair follicles and the face or body. Busulfan is safe and effective for treating dermatophyte infections of the skin. Vitaconazole and terbinafine are excellent anti-against dermatophytes and can be used for shorter course of time. than busulfan. Fluconazole is less effective than fluconazole or terbinafine for treating the dermatophytosis. Fluconazole has excellent activity. It is used and maybe to the treatment of choice for many forms of mucocutaneous candidiasis. So fluconazole and terbinafine all cause elevation of liver function. So ketoconazole is no longer recommended for treatment of dermatophytosis. It is used more than one. We'll see some non-specific antiseptic agents. Agents like iodine solution, ultraviolet, silver precautions, zinc pyrithrone, and finally sodium hypochlorite are used as an non-specific antiseptic functions. Keratolytics. So our keratolytics are soften and facilitate exfoliation of epidermal cells. Example, 2 to 6% salicylic acid and urea. Salicylic acid used to treat psoriasis, seborrheic dermatitis, acne, and warts. So adverse effects are burning. And if large areas are covered, especially toxicity, it should rarely be used in children and infants. Urea is another agent used to treat cancer, keratodermis, and psoriasis. Adverse effects are irritation and tractable burning. It should not be applied to large surface areas. So astringents. So astringents are drying agents that are precipitate protein and shrink and contract the skin. The most commonly used astringent is aluminum acetate solution. It's usually applied with dressing or as soaps. So astringents are used to treat infectious eczema and exudative skin lesions and weeping pressure ulcers, which as well is a popular OTC astringent. Now we'll see antipruritics. Antipruritics is also known as anti-itching drugs and medications that inhibit the itching are often associated with the following factors like sunburns, allergic reactions, eczema, psoriasis, lichen planus, fungal infections, insect bites, and also contact dermatitis and urticaria caused by plants. So doxycycline is a topical antihistamine that is effective in treating itching of atopic dermatitis and so on. So antihistamines such as diphenhydramine and adaxine also used. Corticosteroids as hydrocortisone as a topical cream. Counter irritants such as menthol, camphor. Local anesthetics such as lidocaine, Promaxine, Rosacrine in topical creams and lotions are used. So topical antibiotics are preferred over systemic drugs. So when small surface areas of the skin are affected, antibiotics is not intractable. So calamine lotion is most soothing than antibiotics. So there are some complications using topical antibiotic. Number one is allergy. So of the topical antibiotics, neomycin and bacteriacin have the greatest potential for sensitization. So potential sensitizers in topical medications are diphenhydramine, rosacrine, vitamin E, aromatic essential oils, and beet pollen. Preservatives and even the topical steroids themselves can cause allergic dermatitis. Second one is irritation. Precautions of tretinoin, benzoic peroxide, and other acne medications should be applied sparingly to the skin. Sunscreens may cause irritation or an acne-like reaction. The third one is absorption. So drugs may be absorbed in skin, especially through broken or inflamed skin or from under occlusive dressings. The notable examples of topical drugs to be avoided in pregnancy include chlorothiazine or tretinoin. So consult a pharmacology reference source when prescribing medications for pregnant and nursing women. The fourth is for overuse. So topical corticosteroids may induce acne-like lesions on the face and atrophic striae in the body fluids. Now we will conclude this session with this last slide. So if you want to sensible topical therapy, it involves the following things. First and foremost is selection of an appropriate agent and areas of the body affected. the state of this diseased skin, concentration of the drug, the type of vehicle we select, and the method of application. Finally, a defined duration of the use that both maximizes efficacy and minimizes the adverse effects. If we follow these methods, then we will end up with successful therapy. So with this, we will complete the session. Thank you.